This is ERN-RITA patient webinar, centered webinar. The title, Risk of Infection and Immunological Rare Diseases. We have the pleasure to have Dr. Alsina and as co-chair, Dr. Savino Sciascia. Dr. Alsina, who is here for talking to us, is a pediatrician, expert in immunological rare diseases, primary and secondary immunodeficiency in Barcelona, in Sant Joan de I think I see, in Barcelona, that is a big center and a core member in ERN-RITA. And so I give the speech to Dr. Alsina. If Savino wants to say something, I don't know, and then we can start.
Just thank you all for being here and for creating this space. So thank you, Dr. Alsina, to be with us. And I have to say that it's really a privilege for us to have you as really a leading star, especially in a topic so important for all us, patients and physicians. So thank you so much.
So I'm happy to have been invited here, and I think it's a really important question that arises in the clinic. So I think I will try to explain it as easier as possible, and also how we try to manage this risk of infection. So I will try to share my screen. Let me see. Can you see the slides?
Me,
no, not yet.
So
maybe
mostrar. Let me see.
Camille can help us.
No, it says that I'm sharing the screen.
Okay. Okay, good. I see them.
You see the slides now?
I see. Yes, your first slide.
Okay. So okay.
So
if everybody sees the slide, I can start. Do you agree? I go? Okay.
Yes.
Perfect. So let me see if, okay, so these are my disclosures, but they do not apply to this presentation. So I will try to explain to you these concepts. What are immunological rare diseases? Probably you all know them, but I will try just to summarize. What does the immune system do to prevent infection, and how we as clinicians define the risk of infection in a patient, how we diagnose this infection, and how do we recommend our patients to prevent these infections. General measures, but also concrete treatments or prophylactic measures, and also the typical questions regarding travel and pets. So it's really important for us that to understand that this risk of infection that are faced by you as patients. Okay, so immunological rare diseases, we are in the ERN-RITA, so this means that we are in this network that encompasses all these immunological rare diseases, and these rare diseases are immunodeficiency, autoinflammatory, autoimmune diseases. Okay, so these have in common that they are chronic diseases that impact the immune system function, but they are really different between them. Okay, so we have, as a group, we have primary immune deficiency, which is this group here. And we have like some diseases that are maybe better known or more common to hear about, which are, for example, common variable immunodeficiency, severe combined immunodeficiency, or chronic granulomatous disease. This is a group of rare immunological diseases, or primary immune deficiency. But we have these other three groups that are also belong to these rare immune diseases, which are autoinflammatory diseases such as FMF, Mediterranean fever, hyper IgD, CAPS, interferonopathies, or inflammatory bowel disease, very early onset. Then we have severe autoimmune diseases, systemic or specific to an organ, maybe you've heard about lupus or SLE or neuroimmunological diseases. And all these three groups are rare immunological diseases that impact the immune system ability to protect our body against infections. This is what they all have in common, but by different mechanisms. So how does the immune system fight against infections? So the immune system is composed of different organs that I try to show you here, that they are all spread around our body. We have the thymus that is here behind very close to the heart. We have the spleen. We have all the lymph nodes that are part of the immune system, and we have the bone marrow that is producing all this immune system. Okay, so we have organs. We have many cells that circulate around our body, proteins. And what we know better, or maybe are more well known, is the white blood cells, the antibodies, and the cytokines. All these elements protect our body from bacteria, viruses, fungi, and parasites. So what the main cells of our immune systems are the white blood cells, and they play a very critical role. I will just show you some examples of why in particular they are important to fight against infections. For example, phagocytes, which is a type of white blood cell that is also named as macrophages. They engulf and digest all the pathogens, mainly bacteria and fungi. So you can imagine that if we don't have macrophages, so we are not able to destroy these bacteria or fungi. Other important parts of the immune system, such as antibodies, they are produced by a type of lymphocyte that is called B lymphocytes. And when they see a pathogen, they neutralize this pathogen, this bacteria and virus, to avoid that they produce an infection. So not having B lymphocytes or not having antibodies will be a problem for us to fight against bacteria and virus. Another white blood cell that is called the T lymphocytes. They destroy mainly the cells that are infected by virus. So all the immune system is really prepared to fight against infections. And for example, these are the immunoglobulins, that we have these different types of immunoglobulins or antibodies mainly in our bloodstream. We have this IgM, and they are circulating in the blood, and they block these pathogens. These are the immunoglobulins, to avoid that they enter our body, our tissues, and that they produce infections. So for us clinicians, what is defining the risk of an individual patient to have a particular type of infection? So we have two things to take into account. Mainly, what is the rare immunological disease that this patient has? For example, from all these three groups that I was explaining you at the beginning, the diseases that mostly predisposed to infections are the primary immune deficiencies, because as its name says, it's primary immune deficiency. So the immune system is really deficient and unable to control or to produce a normal response to fight infections. So this group, the primary immune deficiencies, have a weakened defense against infections, and they are mostly the most susceptible to infections. So you can have an immune deficiency that is congenital, that you are born with it, so it really will manifest early on in childhood, or sometimes it can begin later in life, sometimes in teenager or young adults. And these are the group of primary immune deficiencies. But then you have another reason why your immune system is weakened and susceptible to infection. And in this case, it's because you use treatments that decrease the function of the immune system. For example, in rare immunological diseases such as autoimmune disease or autoinflammatory diseases, the immune system is continuously overreacting. It's too high, working too much. So what we have to do is to slow down this immune system. And so to slow down this immune system is difficult to control, that we slow down it to normal. Usually we tend to slow down it a little bit too much. So we go back to immunodeficiency, and so we have infections. And so what are these immunosuppressants that are used to control autoinflammatory diseases. We have corticosteroids, we have cyclosporin, we have tacrolimus, sirolimus, JAK inhibitors, or cyclophosphamide as one of the maybe most common drugs. But also there is this increasing number of biological drugs or monoclonal antibodies that they block specific parts of the immune system, such as IL-1, IL-6, or some cytokines that are causing the disease. And so they block specific parts of the immune system that are important to prevent infections. So in some way, it also reduces the ability of our body to fight against infection. So the risk of a patient, of a particular patient, will be defined by or the disease or the treatment that he's on. And what are the type of infection? So immunocompromised individuals are more susceptible to bacterial, viral, fungal, and parasitic infections, all of them. But we will see later on that some particular diseases or treatment will predispose more to some infections over the others. But in general, the susceptibility tends to be a little bit widespread, okay? So patients are more susceptible to have can have respiratory infections such as pneumonia, bronchitis, or sinusitis that are really common in patients with more common in patients with primary immune deficiencies, but they can also be seen in patients with secondary immunodeficiencies caused by this treatment that they are being used. So these infections, they tend to affect the lungs and the airways. They can also have gastrointestinal infections. This is infections in the GI tract, in the intestine, and so patients can manifest with diarrhea. And these are, for example, infections caused by Giardia, which is a parasite, or some viruses, just as rotavirus. But also other common infections can be skin infections, such as cellulitis, that can be seen, for example, after a severe mosquito bite, that you have this redness or swollen area in the skin. You have the zoster, which is the reactivation of the varicella later on in life, that you have these vesicles that are in your body following like a snake shape. Then you can have warts or fungal infections. The fact that a patient is susceptible to infection doesn't mean that all patients will have these infections. Some patients don't have infections, but some others have more infections. So it depends very particular on a particular patient disease or treatment. So this is a table, of course, horrible with many letters, but what I wanted to show is that each treatment that we use to treat an autoinflammatory autoimmune disease that has different names can predispose to concrete infections. So not all the treatments will cause the same infections. For example, steroids, they can cause herpes, just like zoster, candida, which is infection of the mucosa or the skin, and sometimes pneumonia. But each treatment will cause a different type of infection if it causes this infection. So how us as clinicians and doctors, nurses, approach a patient who is immunodeficient or by the disease or by its treatment, and we are concerned about a possible infection. So we will diagnose, infections in a patient are diagnosed through a combination of clinical evaluation, laboratory, and sometimes imaging studies. I want to explain you this because sometimes you will understand why the doctor or nurses are doing some specific tests to you. So this is a way you will understand how we think or how we perform this evaluation. So first, there is a clinical evaluation. The doctor or the nurse will begin asking you about what symptoms you have, if you have fever, if you have cough, fatigue, pain, and other signs of infection, such as redness in the skin, for example. And of course, we will try always to ask about previous infections, because sometimes some infections that you have had once tend to repeat maybe over time. Then if you have a recent travel, to think of a different type of microorganisms that come with by traveling abroad. If you have had a contact with infected individuals, or if you have an underlying disease. That means if you have a diabetes, or for example, or bronchiectasis, because this can favor some types of infections. Then in the physical exam, we will always check the skin if there are signs of infections, or the lungs. If we hear something that we suspect it can be a pneumonia, lymph nodes that we can touch in the neck, for example, and also your other articulations to see if there is a redness or swelling. Then usually, if we really suspect an infection, we tend to order blood test. Then usually we ask for a CBC to see the white blood cells that tend to be up when there is an acute infection. And then we also determine some inflammatory markers such as PCR, C-reactive protein, or ESR, which is the sedimentary, ESR, I don't know how to say it in English. Then we will perform also blood cultures. This is a way that we take some blood from the skin from the patient, and then we culture it to see if there is the bacteria or the fungi is growing. So it's a way to diagnose what type of infection the patient is having. Then we tend to also collect swab and cultures from the areas where we think there is an infection. This can be, for example, in the skin, because if the culture in this concrete media in which the bacteria or the fungi or the parasite is growing allows us to identify the particular microorganism that is causing this infection. So that is why sometimes if we think there is a lung infection, the nurse or the doctor will ask for a sputum analysis, so we can get the mucus from the respiratory airways, or maybe we can ask you for a stool sample, or sometimes urine, or sometimes we need to get cerebrospinal fluid if we really think it's a central nervous system infection. Besides this culture, sometimes we ask for, we also do this type of swabs that help us to do for this specific test and rapid test that we call, for example, PCR, that was really famous for during COVID. It's a way for us to identify infections, even if the microorganism is present in very low amounts. That's why we tend to do PCR in the same sample. And then serology, which is also a marker in the blood, and sometimes antigens. And sometimes if we are not sure, if we are not able to identify the infection, but we really need to be sure there is an infection that is causing the symptoms, sometimes we will ask the patient to get a tissue sample. This is a biopsy, because we really want in an immunodeficient patient to have a confirmed microbiological diagnosis, because the microorganisms sometimes are different than in immunocompetent individuals, and so we want to make sure that we diagnose the better and we treat the patient the better. And sometimes we ask for imaging studies. For example, these are X-ray, CT scan, ultrasound, or MRIs, so magnetic resonance. So, for example, these are chest X-rays. That this is a normal chest X-ray, and this is a chest X-ray in a patient that has a pneumonia. You can see that there is, instead of black, which is the air, there is this white area that is indicating that there is inflammation and an infection. For example, this is an example of a bacterial pneumonia, but this is an example, for example, of a COVID or other viral infection. So we tend to do imaging, but sometimes we have better resolution with CT scan or ultrasound also if we are thinking of abdominal infection. So the important thing is to avoid to have these infections, because we don't want our patients to have infections. So we always tend to recommend very general things. First, patients must have a good hygiene with regular hand washing, maintaining a clear environment. Then we tend to recommend that to avoid contact with with sick individuals, and then have a balanced diet that is rich in vitamins, regular exercise, so that the patient is kept as healthier as possible. Healthy diet with fruits, vegetables, lean protein, and exercising regularly. And avoid conditions that we know that can weaken immune defenses, such as smoking, excessive alcohol consumption. Then we tend to be very proactive to use vaccines, because vaccines are critical for preventing infections, because they train the immune system to recognize and fight pathogens before they cause illness, because they train the immune system before the individual has encountered this pathogen. So they prepare the immune system that when he encounters the pathogen, or the microorganism, he will be able to fight much quicker than if he hasn't recognized this pathogen ever before. Okay, so we recommend immunocompromised individuals that they stay up to date with vaccines, including flu vaccine, pneumonia vaccine, this is pneumococcal vaccine, COVID vaccine if recommended, and others are as advised by the doctor. Sometimes in adult patients, they also recommend, for example, zoster vaccine. It's always what your specific doctor that knows very well your disease and your treatments will recommend your vaccine schedule, okay? But and what is really important for you to know that in general, life or attenuated vaccines are contraindicated in an immunocompromised patient. So this is important because vaccines we have two types of vaccines. Vaccines that are inactivated, that means that only pieces of the microorganism are used, and inactive, and this can never produce disease because it's only part or very inactive microorganism. And so these are the safe vaccines that can always be used. But instead, for some diseases, we are using live or attenuated vaccines. This is, for example, for varicella, for measles, mumps, rubella, for some types of flu. So these are vaccines that are usually viral vaccines, and they are not inactive but attenuated. That means that the virus is really very weakened, but still in a very immunodeficient patient can cause the disease by the vaccine. So in general, you as a patient, you must know that live or attenuated vaccines are contraindicated when you are immunocompromised, but in each case, it will be the doctor that will tell you, yes, you are sufficiently immunocompromised not to use live or attenuated vaccine. Or instead, you are very, very little immunocompromised, so you can use this vaccine and benefit from these vaccines, okay? So this is always something that has to be very discussed with your doctor. Sometimes we also use prophylactic. In fact, it's not only antibiotics, it's antimicrobials. Okay, so we use prophylactic antibiotics to prevent bacterial infections, and this is more common in patients with primary immune deficiencies, less common in patients under immunosuppressants, but still pretty commonly used. Okay. So for patients with primary immune deficiencies, it's depending on the type of primary immune deficiency that the patient has, because this is always very disease specific. You know that there are at least like 500 primary immune deficiencies, and depending on the type of disease, you get a different treatment. Okay, so but in general, common antimicrobials that we use is, for example, Bactrim, that is cimetoprim sulfamethoxazole, that is used because it prevents respiratory infections caused by pneumocystis pneumonia. But also, depending if it's used daily, can also prevent bacterial infection by pneumococcus or by Staph aureus. Then there is also azithromycin that is used in patients with recurrent respiratory infections and bronchiectasis, because it has also some anti-inflammatory effect. And sometimes in patients that don't have a proper function or recurrent bacteria or risk of recurrent bacterial infections and a spleen that is not properly functioning, sometimes they are receiving amoxicillin. So the drugs that are used in patients with immunosuppressive therapies, I mean with secondary immune deficiencies, you have again Bactrim that is used to avoid this pneumonia caused by pneumocystis in patients mainly with steroids or with very high or prolonged dose of steroids and T-cell immunosuppressants. And in some patients that have recurrent viral infection by zoster, sometimes they get to receive this prophylactic antiviral. But again, it's something that will depend on the particular patient disease or treatment. So there is always this concern. I don't want to use prophylactic antibiotics because I am concerned that there will be that I have an increased risk of antibiotic resistance for the other antibiotics that I might need. So it's something, that question that patients tend to ask us, that they are concerned about the resistance. And so this is why the antibiotics that we use for prophylaxis are really very particular antibiotics. Bactrim is not a common antibiotic to use for treatment of diseases, and we know that, and so the healthcare providers, I mean doctors and nurses, we know what are the diseases that are in a country, the resistance of antibiotics, and so we always tend to think about the risk and benefit, of course, of using this antibiotic as prophylaxis. Then sometimes long-term antibiotic can lead to some gastrointestinal issues and secondary infection. This is mainly when we use particular antibiotics that are very, very strong. That's why, for example, we try to use this type of antibiotics such as Bactrim that is very narrow in the spectrum of the diseases of the bacteria he kills. So that's why it doesn't cause that many side effects. Okay, the side effects caused by Bactrim in the GI tract are commonly very, very low. And again, this is the message, that everything is personalized. I mean, no a particular treatment is working for everybody, and so the physician will think what is the best option for each patient in each moment of their disease and treatment. There is another treatment that is used to avoid infections that is mainly used in primary immune deficiencies. This is immunoglobulin replacement treatment. It's usually used in patients that have low levels of antibodies or functioning antibodies or immunoglobulins. These are infusions of antibodies that are donated from plasma from healthy donors, and they are used to boost the immune system of the immunodeficient patient. Because and these are immunoglobulins, because you know that immunoglobulins or antibodies, as I discussed in the first slide, they are important to protect against bacteria, virus, and other pathogens. So this replacement of the antibodies that are not functioning or not present in the patient because of his or her disease is substituted with external antibodies given by healthy donors. And so this immunoglobulin replacement treatment is a life-saving treatment for patients with primary immune deficiencies. Again, for some of them, for the group that clearly benefits of it. And in patients that even by using immunoglobulin replacement treatment, recurrent antibiotics, still is severe immunodeficiency and has very recurrent infections, the patient sometimes might be recommended by the doctor to proceed to hematopoietic stem cell transplantation. Immunoglobulin replacement treatment is less frequently needed for patients with secondary immune deficiencies or under immunosuppressants, because we tend to have other approaches that are really useful, such as vaccines or prophylactic antimicrobials. And this is important because the approach is a little bit different in PIDs and in primary and secondary immune deficiencies. Sometimes you will have heard also of immunoglobulins that is given to you as a patient, not to prevent infections, but instead to treat autoimmune diseases. In this case, the immunoglobulin is given like in a high dose, and it's given in a very short term to avoid to try to control autoimmune diseases. But this is a different function of the immunoglobulins. Immunoglobulins can be given intravenously or can be given subcutaneously under the skin. I will show you like 2 pictures. Both of the methods, they replenish antibody levels and reduce the risk of infection. And of course, this immunoglobulin therapy have side effects, sometimes like swelling at the site of infections, and sometimes patients that they refer they have headaches and flu-like symptoms in the day after receiving the immunoglobulins. And sometimes severe reactions, such as type of allergic reactions, occur because somehow these are treatments that are given by a donor. It's not your own immunoglobulin, but given by a donor, and sometimes you can have like an allergic reaction to it. And you might have heard that immunoglobulins, they come from donors, from plasma donors, and during COVID there was a really a very severe problem with plasma shortage, and that this reduced the quantity of immunoglobulin that was available for patients. And so this is really important that we enhance as a society or as a group, like the plasma donation, to ensure that every patient that needs immunoglobulin replacement treatment receives it accordingly. These are the pictures of how immunoglobulin is given. If it's given intravenously, it's given usually at the hospital, but sometimes it can also be home given. It lasts around like 4 hours. And it's usually monthly, and instead subcutaneously, if the family is well trained and is prepared, can be given at home. It can be given like week, depending on the product, like 2 times a week or weekly, or even a push like in a daily dose. It depends on the way the patient is trained to administer this medication. Of course, immunodeficient patients, we always try to ensure that the patients have their life as more normal as possible. They have so of course travel is included in the daily life of any person. So we tend to just recommend that before traveling, just to consult the doctor about if there are some vaccines that might be necessary for the place they go, and some health precautions. And in general, in high-risk areas where we do not know how good the water is or how well controlled it is, we try to recommend, of course, bottled water, always maintain a good hygiene during travel, and always be aware that the food is an important transmitter of infections, and so there are raw food is much more at higher risk than all the food that is that can be peeled or can be boiled or can be much more controlled. Okay, so this is general rules. Then, of course, pets is a common question, how pets can carry germs, and they may pose risk to immunocompromised individuals. This type of infection that come from pets to patients, they are called zoonoses, and sometimes this infection, they come from directly from the respiratory tract. They are airborne. Sometimes it's through vectors. I mean that with a flea that comes from the pet to the person, and sometimes with direct contact with the skin or with the feces from the patient, with the saliva, or sometimes with the milk products or egg products that come directly from from the animal. Okay, so the benefits of pet ownership outweigh the potential risk of disease in people and of course in immunodeficient patients. So they are just, I will give you just general recommendations to ensure that having a pet is low risk for any disease. Okay. And because this risk can be minimized, including the immunocompromised, if we practice basic preventive measures. These are just like a summary of the types of infections that can be transmitted by particular animals. And so just for you to have it here, of course, your doctors knows it perfectly. So just is to know that cats, dogs, reptiles, fish, and birds, they can transmit particular infections. So how can we keep ourselves and our pets healthy? We have to wash our hands with soap and water after contact with pets or feces. Wash our hands after working in dirt. We have to keep our vets healthy and have them regularly examined by a veterinarian. For example, if the pet has diarrhea or the pet, for example, is vomiting, we want our veterinarian to tell us if he's having an acute infection, because sometimes it can be, for example, Campylobacter, and it can go to us. So if there is a concern about the acute infection in our pet, we have to consult our veterinarian. Always recommend avoid your pets, I mean dogs or cats, eating undercooked or raw meat, because they can transmit some of the infection that I have shown you in the previous slide. And avoid them to get into garbage, because this is where they can find this. Don't allow them to hunt, eat feces, and drink from toilet bowls. Try to avoid your pets to be free of fleas or ticks. And avoid being bitten or scratched, and keep the nails of your pet trimmed for indoor pet. And of course, if you have a concern, consult your physician or veterinarian, because of course I am not an expert in this. So are there pets that should be avoided? Sometimes we know that pets younger than 6 months are more likely to carry diseases. Animals with diarrhea should be checked, because there are some infections that can be present. Stray animals and wild birds should be avoided, and exotic pets and reptiles, amphibians, because they are major sources of salmonella. So that's why it's also not recommended. And so just as a summary, as a takeaway, I would say that individuals with immunological diseases are at higher risk of infection, but we have good measures for prevention through good hygiene, vaccines, and treatments like antibiotics, antimicrobials, or immunoglobulin replacement treatment that are essential. It's very important that early detection of infection is crucial, because that's why you have to have regular checkups, vaccination, and maintaining a healthy lifestyle can help mitigate the risk of infections. And always consult your healthcare provider for personalized advice. And we have a very good teamwork between doctors and nurses to ensure that the patient can be, that they can consult us quickly. And also there I show you like some IPOP information sheets that are really nice, and also this app that they shared. And I think I'm done, so I will stop sharing.
Okay. Thank you, Dr. Alsina. Very, very interesting for us, and such a big overview in a very, very big topic. So a difficult topic, but I think not for you. That is your daily job. And if there are any questions, I think you can write down in the chat, and our organizer Camille can give us or if you want it, I think maybe it will be allowed for the connection, as we are not so many of us, so maybe we can also ask directly the question. I don't know if Camilla has any question already, but I do have. I will break the glass if Savino wants to say something, of course. Okay, so my first one maybe can be of interest for other people. Would like to ask about vaccination, but in secondary immunodeficiency. I know sometimes they, when you are in immunosuppressant therapy in autoimmune disease or autoinflammatory disease, infection, vaccination maybe work a little lower, and I think there are differences between which kind of therapy, drugs, and the amount of drug you take. So don't want to have a specific reply, but if there are any issue that can be counted.
So I think what is important is to differentiate between what is safe for you as vaccination in secondary immune deficiency. So only inactivated vaccines are safe, okay? And maybe attenuated or live vaccine, maybe they are not safe for you. It depends on the treatment of the drug. Okay, so they are safe. The second point is how effective they are, this inactive vaccine. They are probably less effective because your immune system is weakened because of the treatment. But nevertheless, at least part of the response is there. Maybe if immunocompetent individual, imagine, has 100%, you might have 50% of response, but still it's 50% already. So you must go for it. So it's important.
Always better to do.
We understand that, yes.
Okay, thank you. I think we have no questions so far, but maybe I can go on with my questions.
Go on, go on.
I don't have so much, don't worry. Also on vaccination, do primary and secondary immunodeficient patients have to repeat more doses than the other people, have to repeat more times and less intervals? Thank you.
Yeah. So since the response is weaker because you are under immunosuppressant, if at some point you are able to be off immunosuppressant, it's a good moment to try to revaccinate. And so sometimes your physician will check your antibody levels to see how they are, and if they are not optimal, he will say, okay, it's a good time now to boost. This is what we call a booster. And so it's common that you have a booster if you are immunosuppressed.
And so they are safer for sure, because
Sure.
it's what you recommend.
Yes.
Okay.
There is a question from the audience, so about anti-malaria prophylaxis for patients with primary immunodeficiency in endemic countries. What's your take on that?
So the point is that I mean, not all primary immune deficiency are at risk of severe malaria disease in case they contract it. It depends on the type of primary immune deficiency. If the patient is not taken under any medication that really interacts very badly with the antimicrobial used for malaria prophylaxis, it should be taken. And the indication for its use will be the same as indication for immunocompetent. But of course, if you are in an area that is maybe not high risk, is middle risk, probably the threshold for indication of this prophylaxis, if it's an immunodeficiency that is at risk of having a severe malaria, it will be, the threshold will be lower. So at a minimal risk, your prophylaxis would be recommended. So it will be more commonly recommended that in an immunocompromised and in an immunocompetent person.
Okay. I can
Thank
have
you.
another one. I have the privilege to ask. Or if Savino, if
Go,
you have.
Marta. No, please go.
Sorry, I think my last one. It's about travels, so I can go for that. Okay, and it is if there are countries that are contraindicated in some cases, or if there are contraindications for diseases such as primary or secondary, of course, immunodeficiency, or if you prepare well and vaccinate well, you can go anywhere. Difficult one, maybe.
Okay, no, it's important. I mean, it's difficult to, we cannot generalize. I mean, there are two things for me, I would say. One is if your daily medication allows you to live like for more than to live like for a week, 2 weeks, a month. It depends on the type of medication, because sometimes it's not easy. For example, yeah, I can imagine you travel to US and you have to get I don't know, immunoglobulin, your subcutaneous immunoglobulin, and how you take it there to put it there. So it's not easy. So one thing is that, because this is priority, I mean, you must be able to keep on the medication that you need, because if you cannot, then a long travel is not recommended, and so you have to travel short, like 2, 3 days, 4 days, 5 days, or 2 weeks, for example, depending on the treatment. Okay, then the second is I mean, the degree of immunodepression that you have, or the degree of activity of your disease. If, for example, you are with an active flare of disease, in an autoinflammatory, or for example, in a recent severe infection in an immunodeficient, if you want to travel, you have to make sure that the healthcare system there will attend you well in case you are, because you are fragile at that moment, very fragile. So you must ensure that there is a good healthcare system that will attend you there. And before you go, to make sure that you have your updated report of your medication, of your disease, of your activity, and your medication. And so sometimes if you don't have this, you have to take an insurance to make sure that you will have the best healthcare system. And this is, I mean, for secondary immunodeficiencies in general, the limitation to travel is less. For primary immunodeficiencies, for some of them which are really more severe primary immunodeficiencies, if you are not able to ensure good water cleaning, I mean, good general sanitary measures, these are countries that we wouldn't recommend, and we would recommend others, because you might get there an infection that you cannot eliminate this infection, because some infections are difficult to eradicate. So I think it's important to take these two aspects into account. I mean, as the immune system, I mean, the healthcare system in the place you go, and that you have all your updated information, that you can keep all your medication on, and the third is that you can ensure minimal sanitary conditions, to have access to bottled water. I mean, just as minimal as this. Okay.
Yeah, it depends on the various factors, but if you,
this is why I think it's important to discuss this with your physician, who knows better how fragile you are, because maybe you are not very fragile, and so you can go wherever you go, wherever you go.
Very earlier.
Yes.
Before leaving, not
Yes,
the day before.
Yeah, that's why it's important to plan this in advance.
Yeah, thank you.
Okay, I don't see any further questions. I think that we can just use the few minutes that we have really to congratulate Laia, Dr. Alsina, for the terrific job in such a short time to provide us with such an interesting overview on such a complex topic that I would say comes very timely, because yesterday was the World Patient Safety Day. So it was very timely that today in the RITA framework, we speak about one of the biggest challenge that we have, again, both as patient and physician community, that is the infection risk. So again, I think I can speak on the behalf of Marta and all the organizer that we really enjoy it. It was very helpful and very informative. So thank you so much. Thank you for all those who attended, and looking forward to the next webinar. Thank you so much.
Take care.
Thank you, Savino. Thank you, Dr.
Thank you,
Alsina.
Savino and Marta.
Also, in my view, from patient perspective, very easy to understand, very followable. And I would like to thank you, Dr. Savino, for co-chairing me. It was my first time. And I want to thank ERN-RITA for such a group of webinars for patients with very high level speakers and very high topics. So, and very, very good organization, and everything worked perfectly. So what to say more? And also thank to all the participants to join. If you have other questions, maybe we can transmit later to Dr. Alsina if she is at disposal. I know she has a lot to do. She is the head of her department, so I think 1 hour is like 1 year for her. And I think the webinar will be was registered, so if someone missed it, what a pity, but you can recover.
Yes, so thank you all for the invitation, and I'm happy it helped. Take care.
Thank you so much.
Bye-bye.
Bye-bye.